Hi guys, this is Dr. Shannon Clark with Babies After 35. I am going to be joined here soon by Dr. Sara Mucowski of Dallas IVF. She is a reproductive endocrinology and infertility specialist. Ah, there she is. Hold on, let me find her. Hi!
Hey,
I feel like I've not seen you in so long.
I
Well,
know it's
actually,
been
I haven't
way
seen
too
you in so long.
long.
I know. So right off the bat, we're just going to say it. So what year did you graduate residency? What year what
Um,
was that?
2011.
So I did train you then because I was faculty in 2008. We trained, well, Sarah trained under me as one of the MFM
Yeah,
faculty when she was an OBGYN resident. Then
yep.
you went on to go where to do your REI fellowship after your OBGYN residency.
I went to Los Angeles and I
Okay.
trained at University of Southern California, so USC.
Yeah, and then you came back and you're in Dallas now and you've been there for a
Correct.
while, right?
Since I finished fellowship in 2014, so it's been
Yeah,
6 years. Yeah,
right. And so you're at Dallas IVF in
correct.
Dallas, Texas. And so just tell everybody how they can find you and your Dallas IVF on social media.
So on obviously on Instagram, I'm Sara Mucowski, MD. Dallas IVF is Dallas IVF. DallasIVF.com is our website, so you can easily access us there. And we also have a Facebook page of Dallas IVF as well.
Yeah, and I've been waiting to do this to have something with you for a while, and I think this is a really good topic. We're going to actually do a little bit of a spin on it. We're going to do a little bit of the history too for you
Absolutely.
guys to kind of start from the beginning. But also, I share a lot of stuff that Dr. Mikowski share or post on social media because she has some really good information, especially about family building options for the LGBTQ community. So if you're in Dallas, Texas area or anywhere around, she's a great resource for you guys as well. So she always has great Instagram posts, so I always give her credit, but I also share. So I
Thanks.
love to see what you post. And what actually got me interested is when you posted about Invocell, which we're going to go into soon. But let's start
Absolutely.
off by you had sent me kind of an outline about how you thought the talk should go, and I liked it. So let's talk about a little bit about the history. The first IVF cycle, believe it or not, was in 1978. I was 5 years old. I can't believe it's been that long. So
Well,
so yeah, go,
it feels like it's one of those things that it's been a long time, but not really when you think about it,
yeah.
right? So
Mm-hmm.
when you think about how quickly medicine is constantly evolving, I mean, this is within one generation,
Yeah,
right?
true.
This was
Mm-hmm,
within your lifetime.
mm-hmm.
So the first IVF baby, like you said, Louise Brown was born in 1978. The first US IVF baby wasn't born until 1981.
Wow.
And then from there, it was a lot of, I mean, you know how it is in academics, right? They're
Mm-hmm.
not exactly throwing out funds every time something new sort of hits the scene. And so, a lot of the people that trained me were converting old broom closets or custodial closets into spaces to have their lab to put an
Mm-hmm.
incubator in to attempt to do IVF. And so we've really come a long way. But even the advances that we have, while they seem to be these giant leaps, they take a long time.
Yeah.
We didn't have the ability to help sperm fertilize with ICSI or intracytoplasmic sperm injection until 1991. I mean,
Mm-hmm. Yeah.
to me, that's mind blowing, right? I mean,
Mm-hmm.
I was in grade school when that happened. So it just feels like, again, there's just so much that has changed, and it's an ever evolving field, and there's so much research to be done. So while there still, are a lot of great options, there's still a lot to be learned.
Yeah, and because of the nature of reproductive endocrinology and infertility specialty, and also with IVF, there's a lot of medical legal considerations. There's a lot of things that have to be approved because you're dealing with making a baby, and so
Right?
and rightfully so. And that's why, and correct me if I'm wrong, I do from what I've always read and understood to be true is that the USA or United States has a lot more regulations and they than some of maybe other places that around the world. Is that accurate?
Yes and no, right? So
Hmm.
obviously there's a lot that's sort of in play as far as from ethical
Yes.
considerations, as
Mhm.
far as like you said, because we're dealing with embryos that then have the opportunity to become people, that there's a
Yeah.
lot that kind of needs to be regulated with that. But there are other countries too that have even stricter regulations.
Okay.
So for instance, a lot of what we learned about freezing eggs
Mm.
came from Italy. So they had
Mm-mm.
restrictions about creating embryos that weren't necessarily going to be used. So they wouldn't allow embryos to be
Okay.
frozen without knowing that they were going to necessarily be using them from an
Mm.
ethical consideration there. And so it was really a lot of those restrictions that drove the research that now allows us to have great quality frozen eggs.
Frozen eggs. Yeah. Well, I did not know that. So we'll start. Let's actually start with that because that was something I want to talk to you about. I remember back when because and everybody knows, most people know my story. I didn't meet my husband until I was 38. And I remember probably 5 years before that, I'm sorry, maybe 3 to 4 years before that, one of my good friends who's an REI had suggested freezing my eggs. And I blew it off. I blew it off. I was not in the right mindset. And then, of course, once I met my husband, I was like, dang it, I should have frozen my eggs. But vitrification and the technology back when I would have considered it wasn't really there yet. But what was it about the change in how we're freezing eggs, and explain the difference between freezing an egg versus the embryo, that allowed it to be more successful? What was the change there?
Absolutely. Well, first off, the difference between egg and embryo. Embryo is a fertilized egg, right? So the egg is just the female genetic component. It has not been exposed to sperm. The biggest issues, and if you think about what sperm look like versus what an egg looks like, and I, of course, have a lovely picture here of a mature egg, there's a lot of water content in an egg compared to a sperm. And so the old methods of freezing, which were fine for sperm, were considered a slow freeze. And so because there wasn't a lot of water content in the head of a sperm, they survived very well in the freeze-thaw process. Eggs, however, that fluid could create ice crystals. And so if you think about, as kind of ice or even like a sugar crystal forms, right, it's really jagged. So it can cause a lot of damage within the egg cell. And that's why we didn't really see kind of the freeze-thaw rates anywhere near the numbers we were seeing for sperm. So the newer method, or what's called vitrification, is an ultra-rapid freezing process. And so what happens is it's kind of almost like an antifreeze process where they're exposed to chemicals that first dehydrate the egg, and then the ultra-rapid cooling doesn't allow for that ice crystal formation. So that way those frozen eggs are less likely significantly to be damaged compared to the old slow freeze methods.
So was the damage more when it was getting frozen or when it was getting thawed, or both?
A combination of both, right? So as those ice crystals form and those jagged edges happen, we're damaging that cellular material within the egg. And then upon the thaw process, right, those are then kind of breaking down, and we're having damage on the egg as the thaw happens as well.
Gotcha. So the process is called vitrification. It was the way they were freezing the eggs that allowed more eggs to survive the thaw, if you will, and the freeze, and have more ability to be fertilized and go on to form embryos. So with that being said about egg freezing, while we're on the topic, this is babies after 35. I hear more and more women after age 35, and especially around that 40 mark, asking me about freezing their eggs. Of course, my answer is always you just see an REI and let them give you the advice. But generally, what is the best age to freeze your eggs? And would you ever tell anybody to not do it? Is there any reason why you would tell a woman, especially of advanced age, not to freeze their eggs or not try?
So the only reason I would is if they're not even a good candidate for IVF, right? So we have good markers of ovarian reserve. The big thing we can't predict is egg quality, right? So as we get older, the number of our eggs decline, and the quality of those remaining eggs is diminishing as well. And all of the tests that we have with current technology, none of them assess egg quality. So we have to kind of keep that in mind when we have the discussion. Obviously, the more eggs we have, the greater the chance that someone in that cohort is a good quality egg that could result in a healthy pregnancy. But for instance, if an FSH level is over 17, the statistical probability of having a child with your own eggs once we hit that number is extraordinarily low. So that's when we kind of have to have a really individualized sort of heart-to-heart about what your family building goals are.
And is there a magic number of eggs that is ideal to have to freeze? So I'm sure there's some women who have to go through more than one cycle process to freeze eggs. Is there a magic number of eggs that you guys prefer to have frozen for that process?
It's going to be really individualized, right? So based on the patient's age, their markers of ovarian reserve, and what their ideal family looks like. There are some statistical probability websites out there where you basically type in age, number of eggs, and then it gives out the probability that that cohort would result in at least one live birth, or Y probability that it results in 2 live births, and so forth. So if you tell me you want a really large family, you want 3 or more kids, we may be talking about multiple cycles to kind of get to those numbers where you're comfortable. Right.
Okay. And then of course, there's always that option as you get older, and if you want to try to freeze your eggs, I tell them, similar, I'm not an REI, but similar to what you said, but it is an individual thing, and it does depend on how many eggs you get, what your family planning goals are. And I always caution them, you may need to do more than one cycle to get enough eggs. So as long as they go into it understanding all that, then they can help make the decision for themselves as to how far to go with the egg freezing process. Would you agree?
Absolutely.
Yeah. The other thing I wanted to check, you mentioned something in the thing that you sent me about the lab. There's so much. Listen, you guys are the face of REI. When we go see you guys, we see you and we talk, but there's so much behind the scenes.
Absolutely.
I want to take a minute to give a shout out to the embryologist, because I know that that is a huge factor in the success of any REI center. Why is that?
Absolutely.
Yeah. Why is that? Why is embryologist so important? Or embryologist? I'm sure you might have more than one. So why is that so
Absolutely.
important?
So it's the whole combination of everything, right? So there are minimum standards that are set in place by the FDA and what's, kind of recommended as far as lab quality and how we keep those embryos kind of separate, and the pH and the oxygen tension and all of these things that go into nourishing the embryos, right? We're trying to create that environment like the fallopian tube, but in a lab. So there's the actual lab component and the science that goes around just the lab, the incubator, like I said, the pH, the oxygen tension, making sure that those embryos aren't contaminated in any way, shape, or form. And then there's the embryologist, who's responsible for creating and caring for those embryos and making sure that all of those benchmarks are where they're supposed to be. So that is a huge component of IVF success. So you can have the most skilled physician, but if the lab is poor quality, you're not going to have anywhere near the great success you're going to have if you have both that are high quality.
Right. And sometimes it takes, it's a whole process. It takes sometimes centers years to get to that point, because you start fresh, you have to go through all those processes. But I do know that I get a lot of questions about, grading of embryos too. I don't know. I never want to know how to grade an embryo. I don't understand. It's too far above my head. But is it the embryologist that grades the embryos? And what is the importance of knowing the grade of the embryo?
So yes, it's the embryologist that grades the embryos, and they're looking at a variety of different things in the embryo, but it is purely visual. All right. So for instance, with this particular embryo, it's very clear. We don't see any kind of dots within here. It's very clear what's going to develop into the baby, this inner cell mass versus kind of the rest of the cells that become part of the placenta. So that's a really high quality embryo. But there's a bunch of different things that they're going to be kind of checking off. And so A doesn't necessarily mean A the way we think of it when we get a grade on a test, right? So it's really just a difference in kind of what they're looking at. The other thing to consider is when it comes to visual grading compared to doing genetic testing, say with pre-implantation genetic testing or PGT, they don't correlate well at all. So they did a really good study where they had taken pictures of a bunch of different embryos, and they sent those pictures off to embryologists all over the world. And they asked them to grade them and say which ones they thought were going to be most likely to result in a live birth. What they didn't tell the embryologist was that they had done testing on all of those embryos and know what the genetics look like. And so not only was there a lot of variation between different embryologists and the grades that they gave, but the difference between what they thought was going to be the best embryo and what was genetically normal also didn't measure up very well. So I tell patients, especially if they're planning on doing PGT anyway, the visual grade of the embryo is going to be trumped by the genetics every time.
Sure. And so you mentioned also PGT. Of course, women of advanced maternal age, such as myself, are going to be encouraged to do that. But I have been told by, other REIs that I've spoken to, and also colleagues, that it's never a bad idea for anyone to do it. Do you feel the same way? Yes, if it's younger age, then maybe not. But who's the best candidates? Is it for everybody? Is it for certain people? Who are the best people or best candidates for PGT?
So the best candidates are going to be women 37 and older. So that's kind of the magic number where they see that any theoretical risk or issues with doing genetic testing seems to be kind of downplayed by the benefit we get from getting that information. In women 37 and under, it's going to really, again, be individualized, right? So what I tend to tell patients, especially if they're thinking about using it for family balancing, so just learning the genetic gender, right? We learn the X and the Y chromosome, so you can choose boy or girl as far as what we want to put back when it's ready to thaw those embryos. It may not matter for baby number 1 or baby number 2, right? But you might want that information later down the line. And so if that is the case and you think it might be the case, then it's probably worth doing the genetic testing up front. So that way we're not exposing the embryos to another freeze-thaw cycle to do the testing.
So the PGT needs to be done before you freeze it, ideally for the first time.
Ideally. It doesn't have to. There's definitely success with embryos that have been through, 2 freeze-thaw processes. But we're going to try to minimize kind of handling the embryos as much as possible.
Yeah. And so what are some of the new things around genetic testing? We hear about genetics, just the regular chromosomes, if they're abnormal or not. But I know there's a whole lot of things you guys can do for testing for certain genetic disorders or more specified types of disease processes. What are some of the things that can be also tested for along the lines of PGT?
So basically, it has to be something that we know is already in play. So either, the maternal or the paternal side is carrying a genetic issue that we can then look for in the embryos. And why it's so important to know that the parent has it first is because we have to use their tissue or their cells to create a marker. Right? So if you think of kind of going back to the lab stuff, right, and kind of how we expand and make copies of these pieces of DNA, so that way we can make a marker that's specific to that parent. So, right, it's very specific to the gene, and then that parent would be passing on to the embryo. And that way then we can screen the embryo for that very specific genetic defect.
Yeah, and that's something I know. I have a couple of friends that are going through that now with some kind of rare genetic disorders that one of the partners has. So that is a process. It starts with, sometimes they even go into the family tree as well, right? Depending on what it is. So there are things that can be tested for other than just the routine chromosomes and the sex of the baby. So that's also, and that's becoming more and more evolving. I mean, more what you guys are able to do as far as the testing for those types of things is getting even more. When I went through it, is more evolved since then.
Absolutely. And that's one of the things I caution. You mentioned kind of with egg freezing. I'm sure you're familiar that everyone of reproductive age is recommended to be screened for genetic issues that they may or may not have a family history of, or things that are just kind of common enough in the gene pool that they could have an affected child. And while our genes aren't expected to change with time, what can change is the test, right? So for instance, with cystic fibrosis, we may have only been testing for about 100 different variants of cystic fibrosis, say 5 or 10 years ago, but now we're testing for over 200 variants. So it's just a matter of kind of being aware of what's out there and what can be tested for, and then therefore what can be screened for in the embryo.
Yeah, and so for those women who are, or couples, or individuals who are wanting to determine whether or not they need to be screened for something beyond what PGT traditionally offers, is that something that a genetic counselor, you guys work with genetic counselors and they could talk to them to see if there's anything that needs to be tested for, or how does that process work?
So typically it's based on just kind of ethnicity, family history, those types of things. But there are these kind of super panels that are out there that can screen for hundreds of different types of mutations, largely for recessive disorders. And that's something, I typically caution, if it's something that you want to know as much information as possible, then that's the size test for you. If you're comfortable with just kind of what's the basic recommendation, that's fine too. But especially if we're planning on going through IVF in the first place, right? The more things we screen for, the more likely something's going to be positive. Now that's kind of a stressful factor. Now we have to test your partner to see if you're also a carrier before we have that 1 in 4 chance of an affected child. But again, if you're making the big investment to go through IVF and do genetic testing in the first place, a lot of the companies that offer that initial screening offer free genetic counseling. So if you do end up positive for something, they have a genetic counselor that's going to go through what those risks look like for you, as well as helping with some of the financial burden that goes with doing the genetic testing for that particular marker.
Right. And so the reason why I'm bringing this up is because that is not necessarily new, but it is emerging. It's something that's constantly evolving, and what is available for people to consider for testing, especially along the lines of PGT, is expanding. So it is a conversation. Do you find that it's becoming more, couples or individuals are more interested in learning about that with your IVF counseling as well than, say, when you first started doing IVF?
I think it's pretty mixed. I think initially a lot of times people were already doing things like 23andMe, which obviously is not necessarily recommended as a physician medicine side of things. But so there is definitely an interest in it, but then there are the other people who are staunchly against it. Right? So there's kind of always that wide spectrum when it comes to fertility treatments.
And one of the other things you talked about was better blastulation along with the laboratory thing. What does that mean? What does better blastulation? Because I know what a blastula is, but what does that mean?
So again, kind of thinking back in the history of IVF, right? As things have evolved, our ability to sort of grow embryos further and further out has gotten better. So typically, even when I was in training, we were still looking at largely using what we consider day 3 embryos, and they're only about 8 cells. So at that point, it's really hard to determine what's going to develop into the baby part, what's going to become the placenta, getting a better idea of the quality of that embryo. And so now things have really gotten pushed out to what's considered the blastocyst stage, where there's about 150 cells. And again, it's really clear there what's going to develop into the baby portion and what's going to become the placenta, and getting an idea sort of the grade there based on those couple of things. And so one of the big things that sort of has changed the lab and why we were able to kind of push forward to those blastocysts, which is anywhere from day 5, 6, maybe even day 7 of development, is changing kind of the media. So instead of doing kind of multi-step where we're changing out the media based on kind of what we think the embryo needs at that stage, we now have just single steps so we don't have to disturb them as much. And we've also changed oxygen tension. So initially we were planning, the idea was, well, we want the oxygen tension at what we see in the atmosphere, right? Which is around 20%. The reality is embryos do better at around 5%, so low oxygen tension. So there's been a lot of changes that have happened on the lab side of things that have really allowed the embryos to grow better in the dish. So we have better quality embryos and more embryos than to sample from.
Sure. So again, it goes along with the lab, and I give kudos. There's so many people in the lab, I can't name them all, but kudos to the labs that do this, because those guys are brilliant, and girls, they're brilliant. So I like the science side of it, but it's something that it's not always discussed. No. So I do want to give kudos to them, because they're the brains behind all of this.
They're
cool
definitely
stuff that they're
our
doing.
backbone.
Yeah,
sure.
They are. Yeah. The other thing I wanted to talk about, we already talked about vitrification and PGT, but this Invocell. Okay, listen. I know what it looks like. I still cannot wrap my brain around it. So I need, Invocell is new and emerging for sure. It's considered, and correct me if I'm wrong, it's one of the lower cost IVF options. Okay.
Absolutely.
Start from the top and make me understand.
Okay. So Invocell is an old concept made new again, right?
Okay.
So the idea that, again, we're trying to mimic what's happening in the body, in the lab, right? Historically, when we try to do that as far as creating some sort of vessel to put in the vagina, so we're having the same kind of degree of movement and changes in body temperature and those sorts of things, the big issue is run into is contamination. So Invocell is a new kind of type of material that helps minimize contamination. And it's this champagne cork looking thing here. And I say champagne cork because it is literally
like a champagne,
yeah. Right? It has an outer chamber and an inner chamber. All right. And again, so that's going to help minimize any potential contamination. What it does is it allows for there to be a lower cost of IVF, because we are taking out the laboratory component side of things largely. So wait,
you retrieve the eggs, right? And you just put the eggs in there, or you put the eggs in there with the sperm?
Eggs and sperm go in. Okay. So fertilization is still happening in the woman's body, and the original kind of nourishment of those embryos up until day 5 is still happening in the body. So at that day 5 mark, we take the device out of the vagina, hand it off to the embryologists, who under the microscope take into account all the eggs that went inside of that device in the first place, and kind of assess what happened. There may be some eggs that didn't fertilize and just died off. Just like traditional IVF, there are going to be embryos that started and just didn't finish developing, so they died off kind of in the media. And then hopefully we've got good looking blastocysts to put back inside the uterus, so it would be a fresh embryo transfer.
That's what I was going to ask you. So yeah, it's those, if you do Invocell, it's not going to be, embryos are not going to be frozen.
Well, there will definitely be, the plan is for a fresh transfer. Now, if there's extra embryos, you can pay to have those frozen, right? Gotcha. So that you can have the opportunity to use those embryos, if not successful, for the next go around, or for siblings in the future.
Is there a maximum amount of eggs that can be put in there, or a minimum amount of eggs that can be put in the Invocell?
It varies by program. We've kind of found, for us, what works is about 12 eggs, right? So just like kind of a tank of gas, right? You can only go so far in a tank. Doesn't matter how good quality the gas is, right? You're not going to be able to go indefinitely. This is a pretty small volume that we can put in here. So what happens is the eggs are incubated with the sperm for 5 minutes. So we don't put the whole semen specimen in this little component. And that way, if you kind of think about the fact that those eggs are still surrounded in that cloud of cells that have been nourishing them as part of the follicle, the sperm get kind of embedded in that cloud of cells. And so that way there's sperm around the egg, but fertilization hasn't quite happened yet. But those should be some of the better quality sperm. And then we put all 12 of those eggs with the cumula orifice, or that cloud of cells, as well as the sperm, in some media in that inner chamber.
And that you said it stays in the vagina for 5 days? Okay, 5 days max. And so I heard, where I initially heard about this was with a lesbian couple, where one woman got the eggs, and then her partner had the Invocell for, so So she gets to carry, or does it, or she
So
just carry? Oh,
this
in the Invocell.
allows same-sex female couples to both carry the same baby.
Right. So but the one partner carries it for the 5 days and then takes it out, and then the eggs go back into the original person you got it. Right. Okay. All right. Yeah. So I was like, how is that? That is crazy. I thought it was like some kind of, I don't know,
sounds very
made
sci-fi.
Up story. It does sound very sci-fi. So yeah, I mean, that's pretty cool that that's possible for any couple. But yeah, so for 5 days, and then the eggs go back, and then you transfer the embryo back into the original
uterus.
The original uterus.
Right? So eggs and uterus are going to go together.
Yeah, but it's going to be part of a fresh embryo transfer is what's important. And then any leftover eggs are going to be frozen. Or sorry, embryos. You're right. Okay. Any other leftover embryos are going to be frozen. So that's really, really cool. So can you give an idea of what is the difference in the cost between that and a traditional IVF cycle? Like how much money would it save?
So it can be about half the cost.
Okay.
Right. So we're obviously then not going to be able to do things like ICSI or help the sperm fertilize. Like I said, we're just kind of pouring some of those sperm on there and hoping that the best quality ones are going to be close to the egg when we put them in the device.
Mm-hmm.
And we're taking out things like PGT, that sort of thing, because again, we're typically growing those embryos to day 6 or maybe even day 7. So if you're going to be doing that anyway, you might as well just start from the dish from the get-go.
Okay.
Right.
Okay.
So we're typically quoting the Invocell cycles at around $6,000.
Okay. So again, no PGT, no ICSI, any other things that you cannot do with Invocell?
Those would be the big ones. And again, if you're planning on doing, a frozen embryo transfer from the get-go, then that may have an additional cost to it. Because again, the idea is really for those couples who don't have IVF coverage, who are really good candidates for IVF. Say maybe there's a tubal ligation or something like that, where they just want one more kid, right? So this is going to be the most cost-effective for those women that have had their tubes tied, who may not necessarily want to undergo reversing their tubal or doing full-blown IVF. So it's a really good
since you brought it up, the tubal reversal, that's a very, very common question I get. I don't know what question I'm trying to ask here, but I would say that what people ask me is, should they get their tubes try to get their tubal reversed versus going to IVF? Because if your tubes are tied, what's the layman's term? If you've had a tubal ligation or any kind of tubal sterilization technique, the idea is that you go into it knowing that it's going to be permanent. Okay. Yes, women, there have been failed tubal ligations, but that's very rare. It is considered a permanent procedure, but then say later on she's changed her mind or has a new partner and decides that, should I do the tubal reversal or should I do IVF? Now, I'm pretty sure the tubal reversal is going to be cheaper, but the success rate, yes or no? Maybe
they're apples and oranges. So it depends on how it's done, right? So if it's something that requires, if you're using, an operative microscope, it is a mini laparotomy. So it is a small incision on the abdomen, but you may end up then being in the hospital overnight.
Okay.
And so most insurance companies, while they may have covered having your tubes tied in the first place,
they won't cover that part.
Don't cover the reversal. And so then you're on the hook for an overnight stay in the hospital, which can be really expensive. Again, it's apples and oranges comparing the number of times you have the opportunity to get pregnant, right? So if the tubal reversal is successful, you have as many times as you have ovulation cycles, right? To potentially get pregnant versus that one IVF cycle. It's usually, again, it's a very individualized conversation as far as what are your overall family building goals? If we're looking at just one more child, are we looking at multiple children? What are your plans for birth control after you finish growing your family? Those kinds of things. And then kind of the cost benefit analysis. Yeah,
and I do want to encourage women, and I am in no way taking anything away from what general OBGYNs can do, because there are many general OBGYNs who can do certain things regarding fertility treatments or tubal reversals. However, I do think, and this is just me, I do think that if that is consideration, you should always at least get a consult with someone like Dr. Mucowski, because they might ask other questions and help you tease out the right way to go either way. It doesn't mean you have to do that, but you can still stick with your general OBGYN, but at least get that second opinion. That's what I'm going to say about that. I think I hear a lot, that's not being done. And I fully support that, at least for consultation, especially if we're doing something like that. I also think that there is a common misconception that women feel that they go to an REI specialist, that you're going to write out a prescription for IVF and be like, that's the only option you have. And I say every chance I get, that is simply not true. REI docs such as Dr. Mucowski can do a lot of things. if they can get you pregnant without doing IVF, that's what they want to do. So they understand that there's other ways that they can help you besides just doing IVF. It's not like they're just going to say, that's the only option you have. When can I sign you up? So it's always helpful to just go and talk to someone such as Dr. Mucowski, any REI doc, about what situation you're in before you ultimately make that decision about which way you're going to go.
Every new patient consult I have, at the end, we are going through a ladder of different treatment options. And it's a matter of what you're comfortable with, right?
Yes.
To be as aggressive as you want or as conservative as you want, you know, assuming that we have those options, right? If your tubes are tied, well, doing insemination or IUI isn't really something that's going to be worthwhile. Right. But we're going to have that discussion. We're going to talk about pros and cons of the options that you do have to you.
Yeah, and you could always get consultations with REI docs, and they can give you a lot of good information. I've heard of many times where patients went for consultation. It was something very minor that they had to tweak, and took the advice from the doc and were successful. So. Absolutely. Going to see an REI does not sign you up for IVF. I promise you, that's not what it is. So again, I go on my little diatribe here, but every chance I get, I always put that out there. I think it's important for women to understand that. We talked about Invocell. Now, this other, so y'all are getting so sci-fi on me. I can't even go there. What is this artificial intelligence thing that's going on? What is that about helping to individualize someone's chances of having a live birth? What is it?
So it's a company called UNIVFY.
Okay.
And the idea is it is artificial intelligence, and they are individualized to each practice that offers them. So what happens is, for instance, we have contracted with UNIVFY. They have basically combed all of our data for years and years and years to look at our success rates and the types of patients that we see. And it takes into account a variety of things. How long you've been trying, your age, your markers of ovarian reserve, the semen analysis, any previous pregnancies, your BMI, all of these things that can have an impact. And they have a platform with their own kind of, you know, we'll call it, you know, their own kind of computer magic, right? That things get weighed kind of differently depending on what it is. And then after we sort of plug in all of the pieces of the homework that we may assign kind of after that first initial consultation, it spits out your own individualized chance of success doing IVF with our practice.
That's crazy.
And so from there, then we can, again, sort of, once I have that ladder of different options, we fill in the blanks, right? So we'll start then with our most aggressive. If we're doing IVF with genetic testing, this is that %.
Okay.
And then we just kind of work our way backwards. What do we think it's going to be, you know, with if we add shots and IUI, or if we do Invocell, or if we're just going to do, you know, Clomid or Letrozole. Because again, as we kind of work our way up the ladder, we are going to get more successful, right? Sure. It's just the nature of the beast, right? Again, with IUI and IVF, same thing, apples and oranges, right? IVF, we know sperm and egg got together. We know fertilization happened. We know that embryo started dividing appropriately. If we do genetic testing, we know it has 2 copies and only 2 copies of its chromosomes. And we know it made it into the uterus, right? And those are all things we can't account for when we do IUI. And if those things are happening, we don't know where things fall apart, where we get a lot of information with IVF. So it's really, I know you say that we don't push IVF, but the reality is for most couples, it's going to give you your best chance of success because we know those things are occurring. Yeah,
but what I mean by that is that you do have the data there, you know, and women can find that with the SART calculator. I know that's something they have access to where they can put in some of that information you mentioned, but UNIVFY takes it even several steps further.
It takes into account all of those things. So like your age, your BMI, your FSH, your AMH, previous pregnancies, those kinds of things. Like I said, it takes into account the semen analysis and his side of things, takes into account whether or not either of you have been smokers at any point. And it literally spits out what your chances of success are going to be. So this is just an example.
So let me ask you this. Does a couple or an individual, do they pay for that technology? Or you guys
we offer that to every patient. We think it is important to have these couples informed before they go and make the kind of financial, emotional investment that fertility is.
And then just to give it an example, you know, look, I went through 5 cycles of IVF at between age 40 and a half to 42 and a half. Earlier on, my doc recommended egg donor. Now, I wasn't there. Why did he do that? And this is expensive. Yes, of course it's expensive, but I wasn't there yet mentally. But he said to me, and I remember, if you want the quickest and most successful chance you have of having a baby is with egg donor based on these factors. So that's what REIs do. It's, you know, it's how much time are you willing to invest? What lengths are you willing to go? Of course, having IVF could be the most successful route, but it doesn't mean you have to go straight to that. But that's their job, is to look at you and, you know, how you're choosing, what timeline you're on, how many kids you want, what's going on with you as an individual, to let you know what the statistics show. And that's where the UNIVFY, it helps to come in, because it takes in so many factors, right?
Absolutely. And,
Yeah,
and sometimes it's almost, you know, it's a surprise to me even sometimes the things that it spits out. That I've seen people whose chances of success are over 70%. So we quote egg donors typically at around a 60% chance. Just historically, from what we see, you know, over the years of women who use egg donors, right? Those eggs should be young, healthy, good quality. But some of these women have higher chances of success using their own eggs than, say, an egg donor. So there's just a lot that goes into it.
I think that's really cool. I think, and so you're saying that it could tell, you know, based on IVF, with or without egg donor, with or without donor sperm, talk about whether or not they did IUI, they did Invocell, they kind of, but I think that the also important thing is it looks at what UNIVFY puts out for your center is not going to be the same as what it puts out for the center down the road. So they use all the statistics from that center. And I do know that REI centers do keep a lot of statistics, keep a lot of data, because it's important for them to know that for their own education and to make their own improvements. So, you know, and is there a certain, people ask me this all the time, is each fertility center required to report their statistics to some place? Yes,
the answer is no, they're not required to.
Okay.
And so, you know, there's a lot that kind of goes into that. You know, is why are they not reporting? Are they a new center and they just don't have the data to report? Or are they choosing not to disclose their data? The other component to that is too, as with anything when it comes to statistics, things can be massaged, right? So if you're a center with really high success rates, are you excluding patients who are poor candidates from allowing to do treatments at your center in the first place? So there's just a lot that goes into the start, whereas UNIVFY is really just going to be you and that particular center. Right.
So yeah, and I get asked that question too. So I wasn't for sure about whether or not it was required, but I do know that centers do volunteer, and it's just SART, right? The SART. What is that? The Society for Assisted Reproductive Technology. That's where kind of they keep all this,
they're one of the big centers, governing, regulating bodies.
Right. Okay, so let's go into this. We have some time. I get a lot of questions and a lot of things about this. Is I want twins, and I get it. Twins are cute. And I'm just going to tell my own personal experience. I went through 5 cycles of IVF. I had egg donor. I had a miscarriage on my own. I had a failed embryo transfer with the one chromosomally normal embryo I did get from my body. Then I went to egg donor. I failed a transfer of 2 embryos, and then was successful with the second transfer of 2. Yes, I ended up with twins, and I know people say that's easy for me to say. That what I'm getting ready to say is, as an individual, as a professional, and as a person, I am an advocate for single embryo transfer, and you can go into that from your side too, because I almost lost them. I almost ended up losing both of them. I was 21 weeks, and I had no cervix left. And as an MFM, I know what that meant, and I'm very, very lucky that I did not lose both of my babies. So that's how I feel personally and professionally, and I'm not an REI doc. But what is the thought behind single embryo transfer?
So historically, right, again, this is a relatively new field compared to, say, you know, orthopedics or just obstetrics and gynecology in general, right? That the issue is, as technology has gotten better and success has gotten higher and higher, we are now at a point where the risks of transferring 2 outweigh the benefits. All right, so we actually see the higher chance of live birth, so taking home a baby, is higher 1 at a time than putting 2 back. And it's because of cases just like yours, where unfortunately the coin flipped in the other direction and the babies were lost.
And I will also say this, and I'm not scaring anybody. Some of the most complications I see are with twins, whether by IVF or not. Again, I've also been criticized a little bit for, well, it's easy for you to say because you have 2 babies, but I almost didn't. And so that's why anytime I get a chance to talk about, especially with someone such as yourself, about why single embryo transfer is recommended. Go ahead.
Especially now with PGT. So the American Society of Reproductive Medicine, or ASRM, very strongly recommends 1 embryo at a time when we know they're genetically normal. And again, that's because internally we're seeing numbers at about 70% chance of success with that. So again, that's higher than, say, using an egg donor. Anytime we put back 1, anything from 0 to 2 can happen. And anytime we put back 2, anything from 0 to 4 can happen. So that risk just isn't worth it, right? We're not designed to carry a litter. the more we're
Yeah.
pregnant with, the risks go up exponentially. I know you know this as a
Mm-hmm.
maternal fetal specialist,
Mm-hmm.
but it's something really important. And I know a lot of couples feel like, well, I'm going to get the most bang for my buck. I'm going to get two
Mm-hmm.
babies out of this one cycle. But the
Mm-hmm.
reality is, in the
Yeah.
long run, it isn't necessarily cheaper, and it could be life-threatening for a
Right.
pregnancy.
So is there any thought that behind, and I don't know where I heard this, and correct me if I'm wrong, is there any thought, you laid out very well why single embryo transfer is recommended. But is there any thought that if you put two, that if one of the embryos is not ideal, that it could affect the implantation of the other one?
There's been some theory about that. There's also kind of been theory on the other way, right? So if they're kind of siblings sort of co-cultured together, that maybe that has a positive impact. But again, kind of what we're seeing with current technology, any risk of putting back two in most cases is not worth it.
Yeah.
Now, granted, there are going to be some exceptions to that. So as we talked about before, right, as we get older, the number of
Yeah.
eggs declines and the quality of those eggs diminishes. So if we're not able to do genetic testing for some reason, or if someone doesn't want to do that, we're going to be rolling the dice and trying, again, individualizing things.
Yeah.
That, okay, well, if we have two embryos, the likelihood that both of them are genetically normal at, say, 40 is pretty low. So in that case, it may be worth putting back two if we're not doing the genetic testing, because again, we're kind of gambling, really, right? We're hoping that at least one of them sticks and is healthy.
Yeah, and the thought, reason why we did too is because I had failed transfers, and there was no. I did not, for one, think that I was ever going to get two. I was hoping that I would even get one. And when it turned out, I had to be honest with you, when I found out I was having twins, I was terrified.
I'm sure.
Because I know what happens, and it did happen. And I was very well, and I tried to not let my husband in on it too much. But to be honest,
that had to be an extremely big secret to keep.
Oh, well, I'll tell you how much I knew this was going to happen to me as a maternal fetal medicine specialist, and I deal with this with twins all the time. We had just found out we were pregnant, and his enrollment for his insurance came up, and I said to him, "You need to put me on your insurance." I did. I said, because I wanted dual coverage.
Yeah.
And because I knew what was going to happen, and I was right.
But it's not cheaper in the long run.
Yeah, and I knew it was going to happen, and so he was like, "Why you have insurance?" Like, just put me on.
Yeah, good choice, good
just
call.
In case. It was a good call, but I was worried, and thankfully it worked out for me, and it does work out for a lot of women, but in some it doesn't. So long story short is, make sure you talk to your RAI about the pros and cons of both.
And they should be able to give you those and be very upfront with it, right? This isn't something that should be magical, or just because they told you to. There is very strong science behind it.
Yes, yeah. Okay, so those were the main things I wanted to talk to you about. Oh, no, one more thing I want to talk to you about: IUI.
Okay.
Because it's very well lit up in neon that I'm a maternal fetal medicine specialist, but the most questions I get are about REI topics. So I send them in the right direction, or I'll just say, I have no idea what to tell you.
Okay.
But the other question I get, and I see this all the time, and I have my own personal opinions on this, are round after round after round after round of IUIs. I'm talking women are getting 5, 6, 7, 8 rounds of IUIs, and then they ask me what they should do. And most of the time when I see this, and again, I mean no harm by seeing this, is with the generalists. They're doing a lot of IUIs. At what point should someone such as yourself be sought or get a second opinion? Like, is there a magic number of IUIs? Because what I found is that a lot of women end up spending so much money on IUIs, they deplete their resources.
Absolutely.
And now they can't do IVF. And I wish there was I don't think there's an answer. You say after 2.5 cycles of IUI, you need to go. No, but when should they start?
It's going to depend on why we're doing IUI in the first place.
Yes. Okay.
But statistically, we expect someone who will get pregnant with a given treatment to do so within 3 cycles. Right? So X women are going to get pregnant within month 1. Within 2 months, it's going to be X plus Y. And within 3 months, it's going to be X plus Y plus Z. And after that, it just levels off. There's not really any statistical benefit to continuing to doing the same thing over and over and over and over again.
Yeah, and I think that what a lot of people get caught up on is the cost.
Sure. And the fear. Nobody wants to be in my office. I get that. I don't take it personally. It's okay.
I know. It is. And then I hear women came back and say, I've been through like my 7th or 6th, and now I don't have any funds left, and I get that. It's sometimes you don't realize it until you're way on the other side.
Well, and some of that too,
Yeah.
we kind of talked about the LGBTQ community.
Mm.
Some of that is their insurance benefits won't cover unless they've been exposed to sperm for 12 months.
Mm.
Well, a vial of sperm is almost $1,000.
Yeah.
You really want someone to spend $12,000 in sperm before they can get access to any benefits? And so that's kind of, again, it's very individualized where we have that discussion, you know, is it worth that? How many kids do you want? Do you guys want to use the same eggs as sperm? Those types of things. Because again, maybe then doing something like Invocell is the most cost-effective way of growing your family.
Yeah, yeah. And that's, again, I do advocate for anyone to see Dr. Mucowski or any other REI, because they know how to lay it out and say, this is what your decision tree might look like. You have to make the decision, but this is what the tree looks like. You got to decide what's best for you. It's different for everybody. Yeah, it's different for everybody. So having someone that can actually lay that out for you. And I remember when I went to see my friend, the REI, and he put out my decision tree, and my husband was like, what the, like, there's no decisions here. And then, you know, we didn't, I had already had a miscarriage, and I was almost 41. And he said, listen, your best shot is to do IVF. And again, he had encouraged me earlier on to do egg donor, but I wasn't there yet.
Just think about it. Just think about it. Yeah. In the back of your mind.
Yeah, yeah. So that's what it's important to get all those things teased out so you can make the best decision for you and as a couple. You know, what links you're willing to go, and also factoring in the cost. So I am a huge advocate for seeing an REI, even if as in a consultation, because a lot of times they look at a lot of different factors that some other people would not look at. So
absolutely. I mean, I tell my patients, right, when I get literature, right, when I get the Green Journal or I get FNS, I'm not looking at articles about C-sections and safety of X, Y, and Z in pregnancy, right? I'm only looking for the fertility articles because that's me and my patients. So that's all I do.
Yeah, yeah. Good. I'm glad you're not the only one, because I don't look at the fertility stuff.
I'm not afraid to say that. I mean, it's the truth, right? I mean, every once in a while something sounds interesting, and I'm like, that's really cool. Or you published, I'm like, ooh, what's Shannon up to? But,
I know. But with that being said, though, there's so much new information coming out there. Every article that comes out doesn't mean we're changing our practice.
Correct.
We decide based on what's out. You know, a lot of times we need more information before we decide to change things. Otherwise, we'd be changing what we do every day based on an article that came out. So that's our job, is to read the latest research and determine, you know, if and when we're going to implement anything. Right. So that's part of our job. Reading is always a part of our job.
It never ends.
Okay. Well, I appreciate your time. I'm going to close here. I think everybody's just listening. Most of my questions and comments come after this. So don't be surprised if they DM you. You can, let me see. No, that you can DM. It's what is your Instagram handle again?
Sara Mucowski, MD.
And she works at Dallas IVF, and it's Dallas IVF on Instagram too, right?
Correct.
It's Dallas IVF. If you could also send messages to me, and I can forward you, send them on to Sara if I can't answer them. But I thank you very much for all the information you're putting out there. You put out really good content, and you're very helpful. And thanks for giving me content to put out there.
Of course, happy to. I mean, we're all on the same team.
We are on the same team, so I appreciate it. Enjoy the rest of your day. It's raining and stormy here. Hopefully, it's not like that in Dallas.
No, it's actually quite gorgeous. Sorry.
No, it's not. We're getting. I don't even know what storm it is now, but whatever. We're
into the Greek alphabet, which
I know we're in beta. I'm like, the last time I heard we were on Laura and Marco, but now we're already in beta. So
apparently, yeah.
All right. Well, thank you so much, and I'm sure we'll chat again.
Absolutely. Good to see you. Take care. Bye-bye.